Good afternoon, everybody. Thanks for joining us today. I'm Atul Grover. I'm the Chief Public Policy Officer at the Association of American Medical Colleges. I want to thank Congresswoman Allison Schwartz for her support of our nation's med schools and teaching hospitals, and Anna Eston from her office for helping us with logistics and arranging this briefing today. And I really want to thank especially the March of Dimes, who's been a terrific partner to us, and we really appreciate all of the work that we've done together. We've talked a lot recently in the last few weeks of being in session about the scientific opportunities for federal investment in biomedical research. Our med schools and teaching hospitals now carry out about half of all the externally funded research done up at funded by NIH, so it's not all done in Bethesda. And we really have worked with NIH and with the private sector to come up with a lot of the most important breakthroughs of the last century. Today we wanted to focus on the role that NIH and academic medicine play in achieving those breakthroughs for the very youngest among us. So those premature newborns and the care that they receive at neonatal intensive care units or NICUs across the country. And in particular, our speakers are going to discuss how that vital collaboration, and Emily's excited to be here too. She's awesome. She will make friends with any of you. Just go say hi, or she'll come to you later. She's here, Mondays and Wednesdays, and she's here for the buffet. And you know, as you hear about Emily's story from her mom, Michelle, somebody has tissues back there. So I want to thank everybody for joining us, and I'm going to introduce them very, very briefly. Their bios are in the packets that were handed out. Our first speaker will be Dr. Alan Guttmacher, who's director of the Eunice Kennedy Shriver National Institutes of Child Health and Human Development. And we're pleased to welcome Dr. Jeff Gerdes, who's Associate Chair of Pediatrics and CMO for Network Development, and the Associate Chief of Neonatology at the Children's Hospital of Philadelphia, and also Associate Professor at the University of Pennsylvania Perelman School of Medicine. And last but not least, Michelle Stevens, who's been a dedicated volunteer for the March of Dimes, a former congressional staffer, so she speaks your language, and a mother of a preemie, Emily, who was born 3 months early, weighing 1.5 pounds. My kids both clocked in around 9 pounds, so you know, 1.5 pounds, and what it really takes to help that child be successful. But all the sketches are in there. I'm going to turn it over to Dr. Guttmacher, and we'll have a great discussion when our presentations are done. I will be advancing your slides, so just point at me.
Thanks very much, and thanks to the AAMC and the March of Dimes for putting this together. It's wonderful to be able to come talk to you about how this research really has made a difference in truly countless individuals' lives. I want to start actually by stressing that neonatology is a very young science, and young in an obvious way in that it's about very young kids, obviously kids at birth and even slightly before. But it's also very young as a science itself. This happens to be a picture, go back a slide if you would. Yeah, this happens to be a picture of my pediatrician when I was a kid, Dr. Buck. And I grew up in Baltimore. Dr. Buck was my pediatrician, and when I was in 4th grade, I had pneumonia. And we did eventually work with some kind of a strange reverse house call. We went to his house so he could examine me. And we walked in, and I was immediately taken. I don't remember much about my 4th grade year, but this I can still remember the scene. We walked in, his dining room was completely covered by books and what looked to me to be magazines. I later figured out were scientific journals, and I asked him, Dr. Buck, what is going on in your dining room? And he told me he was writing a book about babies and about how to take care of them, and his wife had given him use of the dining room for 1 year. And that his 1 year was 6 weeks left in it. So he had to really work hard to finish his book, which is why he was working from home, which is why we made the house call to his house. So that stuck with me. A number of years later, I trained in pediatrics in Boston, and I'm looking through the library at the Children's Hospital in Boston, and I come across this book, next slide please, which was the book he was writing at that time. And it's the book in which he, in the introduction, kind of apologizes for having to invent the terms neonatology and neonatologist to describe this study of newborns. So this is a young enough science that I saw it being born or whatever in his dining room, yet it's old enough that it produces kids like this. And the progress, so as you're getting ready to hear her story, what kind of progress we've made. Well, a couple of years after that book was published, in 1963, the President of the United States, John Fitzgerald Kennedy, had a son who was born 5.5 weeks prematurely, Patrick Bouvier Kennedy. He was transferred to Boston Children's Hospital, the place where I happened to notice that book some years later, for the top-notch, the best care the world could provide. This was the son of the President of the United States, born 5.5 weeks prematurely. He died within the first couple of days of life because no one could figure out what to do for him. A kid who was born today at 35.5 weeks of gestation would routinely survive and do quite well. You'll hear about kids born even earlier can do quite well these days. And that's because of the research, the scientific advances that have been made since then. Next slide, please. So NICHD, we do a lot of different kinds of research at NIH, but clearly right at the heart of our mission are supporting research that improves pregnancy outcomes with a particular emphasis on preterm birth, and also supports improving the health outcomes, the life outcomes of kids born prematurely. As you heard before, most of the research we support is done at academic medical centers. Only about 10% of the NIH budget is spent in our intramural program where we do lots of research. It goes out around the country, around the world, primarily to academic health centers, but also to private industry and others interested in these areas of research. Next. So I want to tell you just a couple of examples. We could go on, literally we have several day symposia to talk about the kind of advances in newborn care, et cetera. But among the things we've supported are one that look at something called hypoxic ischemic encephalopathy. And this is basically for very premature kids particularly. They can suffer various problems in terms of brain development, et cetera, because of course their brain is designed to be developing in utero at that point, not outside. And this was a series of trials really that looked at the question of how, if you cool down the baby, whole body hypothermia, it sounds kind of space agey, why would you cool down the baby kind of thing? Whether that really had an impact in terms of outcome, and indeed it does have an impact. So these are the kinds of things that people have a hypothesis, maybe this would make a difference. We do the research, we show us whether it makes a difference, and if so, for which kids it makes a difference, and then it gradually becomes incorporated into routine care. Another one, a number of years ago now, people had the idea that for kids born with a particular kind of what's called a neural tube defect or myelomeningocele, it's a problem where basically the container in which the spinal cord exists does not close properly before birth. And what is routinely done for kids born with myelomeningocele, known as myelo, is surgery after they are born to repair this problem. Well, some people had some idea, what about if we went and tried to repair it during the pregnancy? Because much, of course, of the maturation of the neurologic system occurs in pregnancy. And if we repair it after the child is born, we've missed an important window in development, and that child will have a lifelong impact just from the delay in their surgery. Well, you can imagine that operating on a newborn inside the womb is not an easy task, let alone operating on that kid's spinal cord, essentially. So we had to do a trial to see whether that could be done. This was what was known as the MOMS trial, the Management of Myelomeningocele. We got a whole lot of institutions that were doing this to cooperate by sending all of their patients to one of 4 centers in the United States, so it could be done in a standardized way, and we could see what the results would be. And in fact, it showed that if done well, this was very successful. It reduced both death, but also serious developmental problems. It didn't obliterate them, unfortunately, but it reduced the frequency of those in kids compared to waiting till after birth to do the surgery. It was published in the New England Journal of Medicine, which is a very prestigious medical journal. It was picked by something called the Society for Clinical Trials as the most important clinical trial done in the United States that year. The next one. Well, but then there became a concern about lots of hospitals heard, gee, there's this article in the New England Journal that says this is the thing to do. Why don't we start offering it to our patients? Any hospital that saw itself as an important pediatric center wanted to be able to do this because it was cutting-edge science. It also looked good in the community to say we're doing cutting-edge science. But there was some unease. To be able to do this, you required a very good neonatal intensive care unit to take care of the kids after they were born. You required certain levels of other kinds of care. There's a question about who should do the surgery, neurosurgeons versus certain kinds of obstetricians versus other kinds of pediatric surgeons, et cetera. So we were left with this kind of conundrum. We were the place that had supported this trial at NIH. We felt like we'd unleashed this wisdom on the world, but now there was a question about how it was really going to be used and perhaps misused, that hospitals that really didn't have the right kind of facilities might start doing it, which would put young kids, newborns, at real peril. So we use what we talk about as the power of the convener. I think an important part of the federal government that we don't always think about enough. Yes, the budget you give us is very important, thank you. But this power of the convener, we're seen as impartial arbiters who know something about this. We were able to bring back together a dozen different professional societies, so groups of surgeons, others, who actually were sort of fighting with each other over the turf. We should get to do this surgery. You guys aren't qualified. We should get to do it. And we brought them all together, had this meeting, where we got them to play very well together and to care most of all about the patients, not about themselves, and say, gee, what are the standards? What are the kind of guidelines we should have for performing this surgery? They all came together. So this was an arc from somebody having a hypothesis to during the trial to show this work for certain kids in certain circumstances to help them create the circumstances so the kids all over the country could have that available to them and have it available to them in appropriate ways rather than inappropriate ones. Another thing, we support something called the maternal fetal medicine network, basically. And what this brings together is a whole bunch of places, because a lot of times when you're doing research in terms of newborns, et cetera, no one center will have enough patients to be able to do the research. Some research you can do in one center, but much of it needs to be done in multiple places to really get enough kids in it to really see what works and also see what conditions make it work, et cetera. So this is one where there is a question of, in pregnancy, whether you could inject the substance progesterone and whether that could prevent preterm birth, because the best way to deal with preterm birth, we know, is to prevent it. But it's very difficult to prevent. This was a study that showed in women only in women who have a previous history of having delivered prematurely, that injections of progesterone can lessen the risk for future preterm births, and it turned out that this was true in African American women, a group particularly at risk for preterm birth, as well as other women in the study. So this led to the American College of Obstetricians and Gynecologists coming out with a recommendation, which is now widely adhered to use this. So again, research that informs clinical care. Sometimes the most important studies are the ones that show that something doesn't work. Not that it does work. The ones that do work, they get a lot of publicity, but sometimes showing what doesn't work is very useful. For instance, a couple of studies that we supported, one of them looked at 10,000 pregnant women. There was a belief out there that vitamin C and vitamin E supplements would be helpful for lowering the risk for hypertensive disorders, for increased blood pressure in women in pregnancy, a real risk for maternal health. But we did this large study which actually showed that they were of no benefit, which was important in terms of eliminating yet one more hoop the pregnant women were being asked to jump through, and this one that showed had no benefit. Some other clinical trials that looked at a specific antibiotic treatment for pregnant women who developed a particular kind of infection, asymptomatic bacterial vaginosis, and it was thought that if you use this antibiotic, it would reduce the risk for preterm birth because it made sense. A woman's having a vaginal infection, that's probably perturbing the pregnancy in some way to lead to preterm birth, so why don't we treat the infection that will lower the risk? Well, it turned out here, not only did it not lower the risk, it in fact increased the risk. So again, looking at, gee, this makes sense, let's do it, instead of saying, gee, it makes sense, let's do it. Gee, it makes sense, let's look to see whether it really works or not. Important kind of research. An area of research that we're just getting into is to think about the human placenta in pregnancy and its impact on the newborn. The human placenta, I can tell you, is the least understood human organ and arguably one of the most important. It's very important to how the fetus develops in utero. It's very important to maternal health. It turns out it's very important to lifelong health of both the mother who gives delivery to that or delivers that baby and to the baby's long-term health. But we haven't had very useful tools for sort of studying the placenta before. All we do is after delivery, occasionally we look at it under a microscope. There are much better ways. So we have launched this thing called the Human Placenta Project, which has as its ultimate goal, next slide, being able to really monitor placental function in the human in real time, that is during a pregnancy, being able to observe the way the placenta is functioning so that we can, based upon that, know which pregnancies are a particular risk for things like preterm birth or maternal hypertension or other kinds of things the placenta plays a role in, and more importantly, be able to design interventions during the pregnancy to either, we hope, prevent those problems, at least if we can't prevent them, to make them less of a problem than they would be. These are the kinds of areas, there are many areas we talk about that really, I think, very promising areas of future research. This is one where we think by applying some new techniques to think about the placenta, we can really make dramatic changes in the way this is done. This is the kind of research that could only be done through federal support. It could only be done by having multiple investigators at many academic centers working together on it, much like the Human Genome Project was, for that matter. It's the only way you can do it. Federal funding, federal leadership, but very active participation by many, many academic partners.